26, and we're excited here to bring Dr. Jill Ehrenreich-May's presentation, Impacts of Distress and Anxiety on Youth with Misophonia. I'm going to first briefly introduce Dr. Ehrenreich-May, and then I'm going to turn it over to you, Jill. So, Dr. Ehrenreich-May is a professor of psychology and pediatrics at the University of Miami. Her research focuses on evidence-based psychotherapy for youth with anxiety and depression, and she's supported by federal and foundation grants. She has over 200 publications, and she runs a community clinic at Miami to support this research. Welcome, Dr. Ehrenreich-May.
Thank you so much for having me. I'm really honored to participate in your Care Day activities. And I was asked specifically to share with you some findings from a paper that was just published. I put a little box here with the specific information about that paper. It's from the Journal of Clinical Psychology. It's an open access paper, meaning you can read the entirety of the paper at no cost. And that paper is entitled Impacts of Distress Intolerance and Anxiety Sensitivity on the Maintenance and Treatment of Youth Misophonia. Before I go on, I want to acknowledge my co-authors. I particularly wanted to say thank you to Lauren Milgram and Sandra Cepeda, who are two of my clinical psychology PhD mentees here at the University of Miami. Sandra is actually the first author of this paper as well. I want to acknowledge as well the other principal investigator of the study that this paper came from, Adam Lewin, who is a professor at the University of South Florida. I wanted to acknowledge the other two co-authors of the paper, Madison Bigler and Nisa Tonarelli Busto, as well as our funder for this research that is from the Misophonia Research Fund and Reed Foundation. So, as you may be aware, there are no established clinical practice guidelines for misophonia treatment in either adults or children. We do know that some persons with misophonia have other mental health concerns. That's not a surprise at all in youth. You may be familiar with the term youth mental health pandemic that has described the frequency and intensity of rising concerns about youth mental health. A lot of people point to the COVID-19 pandemic as the start of that, but in my domain where we study anxiety and depression, we can actually trace a rise of these concerns for almost 5 to 10 years pre-COVID-19 pandemic. So these are very common, impairing, and pervasive kinds of concerns that affect youth functioning with and without other misophonia symptoms. But what's helpful about knowing that is that we also know that we have effective treatments for those other comorbid mental health concerns, particularly cognitive behavior therapy. Now, importantly, cognitive behavior therapy is not just one thing. It is a family of psychotherapy approaches that often has some differing skills and techniques depending on the youth or problem under consideration. So it's not simply characterized by just asking people to change their thinking or just by one other type of treatment technique, and can be useful for problems like anxiety, depression, obsessive compulsive symptoms, irritability, trauma, etc., with this kind of centralized goal of working to tolerate uncomfortable feelings in the body and to lead to more helpful versus less helpful actions when we do feel distressed. So what do we know about CBT for misophonia? Well, there's been some early adult evidence that has shown that CBT, as we refer to it, might reduce misophonia symptoms in adult. There's been some pilot and early randomized controlled trial work there. And there's some promising early findings with regard to using CBT for adolescents, but that mostly comes from case studies or individual cases that have been treated using CBT. Prior to our recent trial that I'll describe to you in a minute, no randomized controlled trials had been conducted for youth with misophonia. Now, when we're thinking about using CBT for youth misophonia, we might want to think about the wide array of possible co-occurring concerns that might also be implicated when somebody has misophonia symptoms. So perhaps starting with a manualized intervention or a protocol that actually targets a range of co-occurring conditions might be a good place to start. For our recent randomized controlled trial of CBT for youth misophonia, we selected the Unified Protocols for Transdiagnostic Treatment of Emotional Disorders in Children and Adolescents, or UPCA. That wasn't too hard to select because it's a treatment that I developed, and it is an evidence-based psychotherapy for a range of those emotional concerns. We adapted it specifically in this trial for the individual treatment of misophonia over 10 sessions. So what was in the UPC and UPA as what is inside kind of the UPC and UPA? Well, generally speaking, when we did this intervention in the course of this trial, we presented children and adolescents with the same core treatment skills that are typically in UPC and UPA, but we applied them in the context of misophonic triggers and associated responses. So some of those treatment techniques include gaining more what we call psychoeducation about the experience of strong emotions in the body, what we think, what we feel, and what we do when we're feeling strong emotions, how to engage in different types of what we might call opposite or different actions, or just trying out new behaviors to see in kind of a science experiment kind of way if some other behaviors might be more helpful when we are experiencing distress, to be more aware of what we are thinking and what we are doing, using some mindfulness strategies, particularly when emotions are high. And being more aware as well as of what we are experiencing somatically in the body when we are experiencing distress. And, we even practice some somatic experiencing techniques in that component of the treatment as well. We also target being more flexible in your thinking. So you may have a thought about something bad that will happen, or the idea that it might not work out in a particular situation for you. And we try to encourage youth to think more flexibly, not to say that one thought is wrong and the other is right, but just that there could be other things that could be true in a given situation. And we can use logic to sort of think about what it is that might happen most often and how that might relate to what we choose to do in a given situation. We can also apply problem solving techniques when we're stuck in a situation and we're trying to figure out what to do next. And finally, we can utilize strategies that we might refer to as relapse prevention techniques to generalize and build on the skills. It's only 10 sessions, so we might need to work on things continually over time to stay in a more adaptive place with regard to our distress. And UPC and UPA is an interesting choice related to misophonia because the UPC and UPA's purported treatment mechanisms, or the reasons that we think that it works, actually aligns nicely with core features of misophonia. So in the UPC and UPA, we're aiming to reduce negative affective experiences, particularly when we are not in a dangerous situation or no harm is going to come to us. We are trying to improve our tolerance of discomfort or distress, particularly emotional distress as it relates before, during, and after strong emotion states. We're trying to reduce what we call anxiety sensitivity. I'll talk about that a lot more in a moment, but generally speaking, that's this fear of body-related anxiety cues. And we're trying to reduce less helpful behaviors. We're trying to reinforce more helpful behaviors and reduce less helpful behaviors. That is often framed in the terms of avoidance, but again, avoidance that's not helping us to cope effectively in situations. So we conducted, as I mentioned, a randomized controlled trial. This was actually at the time the largest randomized controlled trial to date with youth who have misophonia to test a psychotherapy intervention. We randomized, though, just 43 youth ages 9 to 17 on a 2-to-1 ratio, meaning that about 29 youth received the UPCA and about 14 youth received a comparison condition, which was a progressive muscle relaxation condition with some additional emotion education built in. We selected that particular intervention as a comparison condition because it shared some elements with the UPC and UPA, that education about emotions, of some focus on the body and an awareness of body signals, as well as some mindfulness elements, but it did not include hallmark cognitive behavior strategies, those opposite action techniques, the cognitive flexibility and reappraisal techniques, the problem solving techniques that we believe really are key to targeting emotion dysregulation processes. We called the adapted intervention UHERE, the Unified Protocol to Help Emotions and Auditory Relief, and we evaluated the effectiveness or the efficacy rather of UHERE in this case at baseline, so before treatment, at mid-treatment around week 5, and post-treatment at week 10. What we saw was that, in fact, both treatments both treatments resulted in significant improvements across those 10 sessions. So there wasn't a big significant difference between these treatments. Initially, we thought both treatments appeared to reduce misophonic severity across treatment. The youth were reporting and their families were reporting reductions in global symptom severity. Overall, about half of youth, 47%, were classified as treatment responders, meaning that they were no longer experiencing clinically significant distress related to their misophonia. And they were reporting that they were functioning better significantly. Interestingly, those who were having lesser outcomes were often older or they had more comorbid concerns. And there was pretty high treatment satisfaction across both conditions. So that's good news that both treatments seemed to improve things and that youth and families were satisfied with both approaches. But when we dug into those findings, there were some curious differences that probably did not reach significance because the sample size itself was kind of small. So, for example, we saw a much higher response rate in the UPC and UPA condition. About 54% of youth responded to UPC and UPA in that clinically significant way, whereas only 25% of youth who got that PRT condition had a clinically significant response. And it was a little bit unclear to us if that difference that looked like it was emerging but didn't quite reach significance was due to mechanisms underlying symptom reduction during UPC and UPA, whether those were things that were working well for misophonia the way that they have mechanistically for when we're looking at UPC or UPA for other emotional disorders. So we wanted to look further at two things in particular, two purported mechanisms of change in particular. Distress intolerance refers to individuals' perceived inability to endure negative emotions and related distress, while anxiety sensitivity, as I mentioned earlier, is characterized by this fear of anxiety-related feelings and somatic sensations. These are closely related constructs. They could be comprised as a kind of larger components of what we think of as emotion regulation more generally. And again, they're purported targets and mechanisms of change for the UPC and UPA. And some theory might suggest that these would be the purported mechanisms for treatment change in those with misophonia, but we don't really have any empirical evidence up till now to examine that question a little bit further. So perhaps, again, there's this sort of small difference that we saw in terms of benefits for the UPC and UPA relative to PRT can be explained by some of the change in these mechanisms. So in order to understand this a little bit better, we took a closer look at these two particular constructs amongst those who participated in this trial. First, we examined these at baseline to describe the role of these risk factors in our treatment sample. And what we saw was that the youth in this particular study reported a moderate amount or a medium amount of distress intolerance. They're saying they could not tolerate their distress at a moderate level of severity. They were reporting relatively low anxiety sensitivity, quite a bit lower than what we often see in our other treatment samples, where they just have anxiety, depression, OCD, and those kinds of things. And then we saw a moderate level of misophonia severity. I just want to put a little footnote here that we had to adapt a lot of measures of misophonia severity to be useful in this trial with a sample of youth. And this is definitely one of the future directions we recommend. While they were reliable in this small sample, this certainly bears further work to make sure that these measures are really good measures of misophonia severity and impairment. We then examined cross-sectional and longitudinal relationships among youth-reported misophonia severity, distress intolerance, and anxiety sensitivity in this sample. And as we thought that would happen, or as we hypothesized, youth misophonia severity was in fact significantly associated with both of these transdiagnostic risk factors over the course of treatment. Additionally, we found that at pretreatment, higher distress intolerance and anxiety sensitivity was associated with higher levels of misophonia-related impairment at home, at school, socially with peers. And interestingly, that high anxiety sensitivity, but not distress intolerance, was associated with older age. And this is going to be something to think about a little bit more when we look at some additional findings. But overall, this suggests that distress intolerance and anxiety sensitivity might be clinically relevant to youth misophonia and could be good possible treatment targets. Then, using something called multi-level modeling, we then found that youth experienced meaningful reductions in distress intolerance over the 10-week treatment course. Specifically, and as we hypothesized, youth who received UPC or UPA demonstrated a significant reduction in distress intolerance across treatment, while those who were receiving PRT showed no significant change in distress intolerance across treatment.
You're at about 3 minutes, by the way.
Okay, thank you. Indirect effect analyses indicated that changes in distress intolerance were a mechanism or a means through which the UPC UPA intervention compared to PRT elicited change in misophonia symptoms. These findings align with our prior studies on UPC and UPA, which have similarly demonstrated that treatment-based improvements in distress intolerance are really important to effective treatment for youth with emotional disorders. And although relaxation therapy techniques like those used in PRT have shown moderate efficacy in reducing general distress with youth, with or without emotional concerns, they may not target distress intolerance as directly or as effectively as therapeutic strategies employed in the UPC UPA. In contrast to our findings regarding distress intolerance in UPC and UPA treatment, additional parallel analyses of anxiety sensitivity revealed no significant change across the treatment course for youth in this trial. Findings of no change in anxiety sensitivity across treatment also held up for both treatment conditions. So there was no difference in either treatment condition. Now, as I mentioned, there were lower baseline anxiety sensitivity levels in this sample compared to other clinical use samples who have gotten UPC and UPA, and that might have helped explain why we didn't see any significant changes. Older youth reported greater anxiety sensitivity, greater misophonia symptom severity, and impairment compared to younger youth. And this pattern is consistent with some existing literature suggesting that anxiety sensitivity may crystallize during adolescence as youth become more aware of their subjective physiological experience of distress and how anxiety is being perceived by others. And that may in turn heighten the perception of distress and functional impairment experience associated with misophonia symptoms over time. So clinically, what we can say is that there is preliminary evidence here for distress intolerance as a relevant treatment target or treatment mechanism for youth with misophonia, and that future work with CBT approaches or with the UPC UPA for youth misophonia might benefit from even greater emphasis on tolerating misophonia-specific distress and how that leads to, for that individual, more helpful coping behaviors. And to summarize for anxiety sensitivity, we basically found that there was a significant longitudinal association between anxiety sensitivity and greater misophonia symptom severity. suggesting that those with misophonia who exhibit greater anxiety sensitivity might be more prone to heighten reactions to sound stimuli, which might exacerbate misophonia symptoms. But there was no within subjects rather variations in anxiety sensitivity on misophonia symptom severity, and no indirect effect of changes on anxiety sensitivity regarding the relationship between UP and misophonia symptom severity improvement. So what does this tell us? Well, this indicates that anxiety sensitivity may not serve as a treatment mechanism, or that a key treatment mechanism anyway, of misophonia symptom severity change. And one possible explanation for this lack of observed impact is that individuals with misophonia might perceive their bodily reactions to sound triggers as both distressing and uncomfortable, but not necessarily unexpected. And future studies are needed to further explore this relationship between anxiety sensitivity and misophonia, and maybe particularly focused on the nuanced ways that individuals perceive and respond to physical triggers associated with sounds. So finally, I just want to note a couple of future directions. Certainly, both of these treatments were feasible and helpful, and larger trials are certainly needed overall. We need to be examining these questions in more diverse samples. Our sample happened to have a largely representative subsample of Hispanic or Latino youth, but there was limited representation of other racial, ethnic, or other identity groups. And we want to make sure that these findings, are important and useful for the broadest range of participants to allow for examination of things like demographic and clinical moderators of treatment response, meaning like which treatment works for whom best. And finally, given the flexible modular nature of the UPC and UPA, future studies should examine whether there are specific treatment techniques or specific treatment modules that will elicit the greatest changes in distress intolerance and help with misophonia the most. And that can help us to tailor and personalize the most effective intervention methodologies for youth with misophonia. So thank you so much for your time, and I'm happy to answer any questions that you might have. And that's also my email on the screen in case you have additional questions to direct to me here at the University of Miami.
Thank you so much for this presentation. We're definitely always really excited to hear more about treatment of youth with misophonia. And we do have a few questions in the chat. So first one was there or will there be an investigation on whether there is a longer term benefit of the treatment following the end of the sessions, i.e. 6 months later?
Yeah, I mean, great question. We had a relatively limited amount of funding for this particular trial, and I think that's what led to kind of the smaller sample size and us only being able to look at post-treatment. We would love to look at long-term outcomes. It's been something that Dr. Lewin and I have been working on. So we've been collecting some longer-term follow-up, and we're hoping to be able to put together a publication on that. It's going to be just on a subsample because it wasn't one of the intended aims, and so we're trying to kind of catch up with most of these participants a little bit later. But we're hoping to actually have a more than 1 year post-treatment check-in with some of these participants, and we've gotten through a good proportion of that already. So great question.
Awesome, thank you. We have a couple of people asking if you have a program where you train people to offer this therapy in their practice.
So we have done some. So we have core training on the unified protocols that is pretty widely available. We also offer it for free to South Florida providers through a foundation that supports that here. And we are I've not always been the most entrepreneurial person in terms of making a treatment business, if you will. But I do have some partners now, and we're building some additional workshops on some of these specific adaptations that people often want additional training on, so that they can be more widely available. I would say the timetable for that is probably within the next year or so. We should have some recorded workshops available, and we do some upon request, of course, as well.
Thank you so much. We are now out of time, but thank you so much for this presentation and for